So welcome everyone to the webinar on personality disorders in long-term care. So this webinar is being presented by the North Simcoe Muskoka Specialized Geriatric Services Program and is part of our Leadership and Innovation in Long-Term Care Education sessions. My name is Tamara Nowak-Leonard, and I'm the Clinical Manager and Clinical Nurse Specialist for the North Simcoe Muskoka Specialized Geriatric Services. While we are all joining from different locations, I would like to acknowledge the traditional territory of the Anishinaabeg, which includes the Odawa, Ojibwe, and Potawatomi nations, collectively known as the Three Fires Confederacy. The Haudenosaunee and Wendat nations, and the presence of other First Nations, Métis, and Inuit residing in the Simcoe-Muskoka territory. In doing so, we acknowledge and affirm our commitment to improving relationships between nations and to improving equity for Indigenous communities residing in the regions represented here. Welcome everyone. This webinar is being recorded and will be posted on the NSM SGS website. As a webinar, all microphones are muted. In the bottom center of your screen, you will notice the Q&A button, which you can pose any questions. Information can also be shared through the chat box. At this point in time, I would like to present our speaker, Dr. Kathleen Bingham. Dr. Bingham completed her medical training at Western University in 2010 and her psychiatry residency at the University of Toronto in 2015. She then completed a PhD in medical science through the University of Toronto's Institute of Medical Science in 2019. She is a geriatric psychiatrist and a clinician investigator based at the University Health Network in Toronto and affiliated with the North Simcoe Muskoka Specialized Geriatric Services Program, where she works in the community with hospital teams and in long-term care. Thank you, Katie, and welcome everyone.
Great, thanks very much for having me, and thanks for joining everyone. So the talk today, as Tamara already mentioned, is about personality disorders in long-term care. And this talk just came out of, noticing that, and over the years, I guess, that there are a number of residents in long-term care who have these difficulties, whether it's a true personality disorder or, traits of a personality disorder or personality traits that make managing in long-term care more difficult. So we were initially going to do a smaller talk, but I guess there was interest in expanding it a little bit. So that's why we are having the larger talk today. So again, I appreciate everybody coming. And so I will get started. I don't have any disclosures relevant to this talk. I do have some research funding through the University of Toronto. And my hope for the talk today is that participants will be able to firstly describe types of personality disorders and how they might develop. Second, recognize how personality disorders might present in the long-term care setting. And thirdly, to develop strategies to support residents with personality disorders or, quote, difficult personality traits in long-term care. This talk is going to be relatively short. I'm trying to leave a lot of time for kind of questions and discussion towards the end. So, but I am happy to take questions throughout. So Holly, I think, is going to be monitoring the chat and can just let me know if there's any questions, or you can feel free to unmute. I think if you're able to unmute yourself and ask a question as well, that's fine for me. Okay, so first of all, to actually define personality disorders. So, I mean, we all obviously have a personality, and we all have various different personality traits that are not a personality disorder, but, maybe at various levels of adaptive versus less adaptive. When it becomes a personality disorder, it is a lifelong pattern of perceiving, relating to, and thinking about other people that can cause significant functional impairment or distress. So it's not enough just to have some personality traits, like, again, we all have, that maybe aren't always so useful or adaptive. They have to cause a lot of impairment and distress to be in that clinical category. The DSM defines 3 different clusters of personality disorders. I'm not going to go into all of them in detail, but just to give you an idea of the kind of 3 main clusters of personality disorders. The first is cluster A, and that tends to be seen as people who are maybe a little bit more eccentric. They might be socially isolated, have few close relationships, and they actually are not bothered by that. So they don't necessarily have the same perceived need, at least consciously, for interpersonal relationships that, you know, many of us do. And this group of people actually don't often come to clinical attention because it doesn't bother them. They're not causing a lot of distress necessarily for other people, but there is some impairment in functioning there. Like they may eventually, especially as they get older, they lose contact, they don't have a lot of support, so they may have difficulty functioning as they get older without those social supports that are often needed with aging, for instance. The second cluster is the cluster B, personality traits, and that tends to be what causes the most, what people come to clinical attention for the most. So those are issues like borderline personality disorder, for instance, antisocial, narcissistic, histrionic, and oh, I see somebody has a question. I don't know if you wanted to go ahead or put it in the chat. Look at the chat. No.
I wonder if someone just hit the hand button by accident.
Oh, okay. Yeah, no problem. You can just speak up if there's a question.
Like, wait, I don't see a question.
Yeah, so anyway, so cluster B, again, that's the ones that tend to come to clinical attention the most, and is what I'll be kind of focusing on the most during this talk. And so that tends to present as a lot of emotional instability, anger, impulsivity, really chaotic relationships. And people with this personality structure usually are suffering quite a bit. So it does cause a lot of distress, maybe not so much for the antisocial group of people, but for especially for people with borderline personality disorder, there's a lot of distress associated with it. The third cluster is people who are on the more avoidant, dependent, obsessive, compulsive, like kind of more anxious spectrum of personality traits. So they may not meet full criteria for a disorder, like for obsessive compulsive disorder, for social anxiety disorder, but they have enough personality traits that it causes, you know, disruption to their lives. And they are often isolated, but unlike the cluster A group, they don't necessarily want to be isolated, especially the avoidant people. They often tend to be very isolated, but it's not because they want to be or prefer to be that way. It's just because of the fear associated with close relationships. So yeah, so that's just to give a sense of personality disorders types. How do they develop? So we actually, you know, we don't know how they all develop. It of course involves a combination of biological factors, psychological factors. So it's not just one thing. And especially borderline personality disorder, there is thought to be a major biological component to it as well. But generally speaking, usually there's some type of early life trauma. It may not necessarily be overt abuse, like physical abuse, for instance. It may be more of a severe mismatch between a caregiver and a child in terms of temperament, for instance, and a parent just for maybe their own difficult, like mental health difficulties or history may not be able to meet the needs of the child, even if there's not overt abuse. So by no means, like early life trauma, unfortunately, is common, and it certainly doesn't always develop into personality disorder. So not everybody will develop one. So there's something else that contributes as well. But generally speaking, when we have dependable caregiving, so when we have a good enough caregiver that we can rely on for our needs, we, you know, through early childhood, develop the ability to recognize our own needs, to manage emotions, eventually to trust others and develop stable relationships. Also eventually have the ability to be flexible in our coping strategies. So we kind of know when to ask for help, when to rely on others, when to rely on ourselves. So there's more of that self-esteem and adaptive coping. With inconsistent caregiving, which includes abuse, people can have difficulty recognizing first their needs and emotions. So even recognizing what they might need, which can obviously be overwhelming. Difficulty managing strong emotions. So they may, in that setting, tend to either just withdraw and avoid or become overwhelmed and inappropriately reach out for help. Also have the inability to form really close, stable relationships. So again, they either avoid them completely or they become overly dependent on other people for their self-esteem, or both, like push and pull, which is often seen more in the borderline personality setting. Also limited coping strategies. So an arsenal of coping strategies that may have been helpful at one time in life is not always going to be helpful over time. So often this can look like substance abuse, self-injury, excessive reassurance seeking from other people. So, you know, and why one person might develop into one type of personality disorder for another versus another isn't totally clear. It probably depends on a variety of different factors, but that's sort of generally how they develop. Okay, so what about aging with personality disorders? So of course we know that with aging and the physical challenges and losses that go along with that, that really threatens one's sense of self. So if you don't have a strong sense of self to begin with, the aging process is particularly anxiety provoking, overwhelming, and challenging for a lot of people. There's also increasing isolation when people may already have limited relationships. That just kind of gets worse over time, potentially. There's the loss of previous coping strategies that maybe weren't necessarily adaptive, but were still working to some extent. So things like drug use, sexual encounters, sometimes people will avoid by just traveling frequently and not staying in one place. All of that becomes harder with aging and with institutionalization. So with moving into retirement home or long-term care, well, we don't necessarily want to call all of that institutionalization, but with moving, like the losses and moves that can go along with aging. So specifically moving into long-term care, when people become more dependent especially for personal care, it's as everyone here knows, it's sort of this forced dependency where they really don't a lot of times have an option, but they need help with ADLs and with care. So for people who are very anxious and overwhelmed with intimacy and vulnerability, that's extremely overwhelming. There's also the limited privacy, vulnerability, which is hard for people with certain personality structures. And that really activates some of these more maladaptive coping strategies that I talked about earlier. So we'll talk about how that might look in long-term care. But those are some of the reasons why the long-term care environment in particular, and potentially other environments like retirement home environment, can be particularly difficult for people with certain personality traits. And even if you don't have a personality disorder, if you have certain, just traits or characteristics, they can start to look like a personality disorder if we're under a lot of stress. So all of us, if we're feeling vulnerable enough, some of our less adaptive coping strategies will come out. And so that's the same with, but magnified for somebody with a personality disorder. Okay, so this is where I thought maybe I would get some participation. So I don't know if people want to call it out or put it in the chat, but how have we seen personality disorders presenting in long-term care? So what have people noticed?
If people can write in the chat box.
That's probably easiest.
I can start with, if I think about some of our residents, the inability to please the resident. Mm-hmm. Oh, I'm reading staff splitting. Thanks, Shauna.
Yeah, splitting for sure. So first, inability to please, absolutely. Splitting we'll talk about.
Verbal and physical aggression, blaming staff, easily irritable. Thank you, Magdalena. Withdrawing from activities that were previously of interest, collecting items and filling up the rooms enough that it makes them unsafe, hoarding, overstating the importance of relationships, refuse care attempts, then say nobody came to help.
Yes.
Good one.
Yeah.
I think that goes with all care too, right? Or family never visit, or
manipulation is in here. Talking about disregarding rules or challenging the rules, not following schedule.
Refusing to eat, variation in mood and emotion.
Absolutely. I mean, those are all good examples. I think people have probably all seen, residents with these challenges in long-term care. I mean, I know of course I have. And how do they make staff feel? Like, how do you guys notice that patients like this affect you in terms of, emotions and outlook and everything?
They're still flying them in. Self-harming behaviors or attention seeking, intimidation, will complain of feeling picked on, unstable moods. Avoidance. So staff will avoid.
Yeah.
They're exhausted. Yeah, they can be exhausting for the staff.
Yeah, absolutely. I mean, patients or residents who have these types of personality traits often can just take up so much emotional and mental energy in a shift, right? So
Confusion, frustration,
yeah,
threatening of calling the cops. I think they
yeah.
threaten to go to management. I think sometimes you'll see the splitting between management and staff that they create. Threaten to refuse to provide care.
Yeah, I mean, it's chaotic, absolutely. And I think people are mostly referring here to the cluster B spectrum of personality traits, which really is what tends to be most disruptive and, and distressing. And, I would conceptualize a lot of these things as either being related to inability to regulate emotions, which is kind of a core of especially borderline personality disorder, as well as including maladaptive coping strategies. So, I'm feeling overwhelmed. So I don't know how to regulate myself. So I'm going to frequently call out for help, for instance. And so those are all good examples. I think you've covered everything really that I have on the list, but let's just look here. So presentation in long-term care includes, but isn't limited to, caregivers and family reporting a long-term pattern of behavioral challenges. So it's not something that starts a few years ago. This has been present from the beginning, really lifelong. You might notice challenges in the residents getting along with their roommates, staff, co-residents. So it's not just like a one-time conflict, but it's a pattern of behavior, right? Or for some people, they may not necessarily come to clinical attention as much, but they have a lot of isolation, difficulty even asking for help. They might be very reluctant to reach out for help, even when they should. Excessive anger, suspiciousness, difficulty adapting to routines, black and white thinking, which goes along with splitting. So splitting was mentioned. And so splitting in this setting refers to a pattern where the person with the personality disorder causes, usually it's subconsciously, maybe not always, but it causes very different reactions among like caregivers, for instance. So that could be because of behavior that looks manipulative. So telling, idealizing, for instance, one person while putting down other people, complaining to one staff member about another one, lots of different ways of causing splitting, but that's a very common reaction to the people in the environment to the person with the personality disorder. So sometimes I'll see a patient who with personality disorder and they'll say, oh, thank goodness we're seeing you. Like the other doctors are just terrible, et cetera, et cetera, et cetera. And, it's nice to have a compliment, but I always know that's a red flag. Like they could be saying the same thing about me to somebody else. So when you hear that type of idealization or devaluing other people, that's other caregivers or other people in their lives, that's definitely a red flag to just be cautious of. So frequent calling out, which was mentioned, staff feeling like the person's needs are never adequately met, no matter how much you try. What we can call sometimes chemical coping. So not necessarily like true addiction, but excessive use of medications that usually have sedating or anti-anxiety effects in order to cope. So using an external, coping strategy rather than being able to self-regulate. Stirring up conflict among staff, which we talked about, eliciting strong emotions in staff. And some of those strong emotions can be things like hate, helplessness, shame. Usually it's the person's own emotions about themselves that they're causing others to feel. So people with this type of cluster B, usually personality disorder, can often what they feel about themselves, they're eliciting in other people. So if you feel that way, like if you start to feel like, well, I really hate this person, which happens, right? Or I feel helpless, I feel like ashamed that they're making me feel ashamed about something in my life or about not being able to help, then sort of that's a sign that there is probably something else going on. And often, it's a reflection of the way that they feel about themselves. Okay, so talking about the burnout related to managing residents with personality disorders. So you can see here I've illustrated the cartoons illustrated that it's only been 15 minutes and a 12-hour shift and she's already ready for it to be over. So I'm sure people can relate to that sometimes. Okay, so I've given a case example here. This is, you guys, you might think you know who this is. This is a mix of different people. So it's inspired by a mix of different people. So the example is Ms. B, and this lady is 75, admitted to long-term care because of inability to manage physical needs at home. Doesn't necessarily have really a lot of cognitive impairment, it's more physical impairment. History of arthritis with poor mobility, requiring a 2-person assist, incontinent for urine, has COPD on oxygen. Mental health, there's history of depression noted in the chart. In terms of social history, divorce, 2 daughters, but with limited contact, apparently no close relationships that staff have been able to identify. And staff notice that Ms. B calls out for assistance excessively and for seemingly small needs. So for instance, turning up her radio by like 1 notch when she could have maybe waited, but she decides to just call out for anything and everything. Criticizes staff for the care provided. So, you know, like was mentioned earlier, she'll say you didn't change her brief properly, even though you did it the same way every time. Very focused on receiving her medications on time, and will shout and become angry if staff are 5 minutes late bringing her medications. So just doesn't seem to understand that other people may have needs too, and staff may not always be able to be there right on time. Frequent arguments with co-residents for seemingly minor slights, if anything. And then doesn't seem to recognize how behavior affects other people. So doesn't recognize that, you know, staff are becoming burnt out and will actually be avoiding her as much as possible. And that kind of leads to a vicious cycle of her getting, you know, overwhelmed and afraid that her needs aren't being met, and then escalating the behaviors to try to make sure that she's getting her needs met. Again, not in a healthy way, but this is sort of the way that she knows how to do it. Okay, so management strategies, we'll keep this case in mind and return to it. So the first thing to think about is, are there actually other things that are contributing to this behavior? So if somebody's presenting like this, yes, it definitely may be a personality disorder, but it could also be things like depression, anxiety, even dementia, pain, substance misuse that's disinhibiting. So there are a number of other things that can contribute to these types of behaviors that we have to keep in mind. So that's where, you know, a psychiatric assessment, for instance, could be helpful. The other thing we have to keep in mind is to manage expectations. So these behaviors have been lifelong and are not that they can't improve or be managed, but usually the change has to happen more for us rather than for the person with the personality disorder. Sometimes they'll kind of, as they get used to the environment and settle in, it will improve, because when they first move in, for instance, to long-term care, that's a very vulnerable time and behaviors might be more active than they will be later. But generally speaking, these are core parts of personality that aren't going to change. Borderline personality disorder actually is very treatable, but more so when it's addressed early in life, like with psychotherapy. By the time people get into, you know, long-term care, it's going to be a lot more challenging to change. So unfortunately, the time to address it was decades earlier. So again, doesn't mean that things can't improve, but really most of the improvement, or not the improvement, but the change probably has to happen more with us versus the resident. The other thing to keep in mind that can be helpful is that even though it feels very personal, it really isn't. I mean, it's based on the person's, again, their own self-esteem, their own long-standing behavioral patterns. Even if they're calling names or being shaming, it's really not personal, even though it certainly can feel that way. So that can be part of managing expectations as well. And then the other thing to keep in mind when it comes to management strategies are these 3 C's. So the first one is clarity. So being sure to really establish clear and specific treatment goals and expectations. So we're probably not going to change everything, but what is the most challenging and distressing behavior? Like, what do we really want to focus on? The second is consistency. So this is extremely important for people with especially cluster B personality disorder, who really are very overwhelmed by lack of boundaries and unable to regulate themselves without clear boundaries, and actually having very clear expectations and boundaries is part of the treatment plan. So once a care plan has been developed, it's important that staff adhere to it every time, like having like a lot of consistency. As much, I know it's not always possible in long-term care to have 100% consistency, but as much as possible, it makes a huge difference. The other thing that we suggest is to have, rather than, the resident, reaching out to staff, anyone and everyone for help, to have 1 or 2 kind of trusted go-to people who they can communicate their concerns with. So we've been fortunate to have some help from sometimes the family physicians or the directors of care So people who do have some management role who can actually, listen to concerns and make changes where appropriate, and sort of have scheduled time with them so that staff are able to kind of push off the complaints to that designated time in person. So that will give staff a script that they can use. So I'll give an example actually when we get to the management of the case, but that's something to keep in mind. The third C is communication. So it's important to have a discussion of the care plan with everybody, including the resident, and letting them know that, okay, this is the care plan. This is what you can expect to happen. Anytime it changes, to update them and keep them involved so that they, again, know what to expect. And also to let outside care providers know as well that this is the care plan. So often when agency staff come in, for instance, it can get disrupted, or it can get, the boundaries won't be there because they just don't know. So it's just important to keep everybody in the loop. And then obviously staff experience, as you guys all know, a lot of burnout when managing residents with personality disorders. So having space support for staff, including debriefing, interdisciplinary meetings, allowing for breaks after dealing with the resident, all of those sorts of things can be helpful in, trying to minimize the effect that they can have on stress and burnout. Okay, so for this case, Ms. B, so the plan was a psychiatry assessment where the diagnosis was likely borderline personality disorder, no additional diagnosis requiring medication management. So if the person does have comorbid depression or severe anxiety, there certainly could be a role for medications, but in the setting of borderline personality disorder alone, there's not sometimes, but usually medications don't have the primary role. In the psychiatric assessment, there was a history of childhood abuse noted, along with involvement in multiple abusive romantic relationships. So just sort of more support for that diagnosis. Challenging relationships with families, similar dynamics observed to what staff are seeing in long-term care. So this isn't just in long-term care, it's something that's been observed over the course of the person's life. And during the assessment, Ms. B actually acknowledged that staff are doing their best in providing her with care, but that she becomes angry and overwhelmed when she perceives that her needs are not being met. So she wouldn't have used this language, but that essentially was the communication to the psychiatrist. So it's not that she doesn't have any recognition that staff are not trying their best to meet her needs. It's often just in the moment, the person is too overwhelmed to realize that, and they can't use their rational thinking. So they, it seems like they aren't recognizing that people are trying their best to meet their needs. Okay, so the care plan was developed in collaboration with our team, with the resident and staff. And the primary goal was to reduce the most distressing behavior, which was the frequency of calling out, which was happening like every 5 minutes. So the first step was attempting a pro-attention plan where staff would check in proactively every 30 minutes, we said. If she called out in between, which would certainly happen, the plan was for staff to just provide a brief check-in, like look in her room to make sure she's not in acute distress, like she's not choking or something. Otherwise, just letting her know that we'll address the concern when we come back in 15 minutes, like at the next scheduled check-in. This does require a lot of consistency, and it can behaviors can escalate before they start to reduce or to extinguish. So it's important to kind of keep going with this pro-attention plan if it's thought to be helpful. Also encourage staff to provide praise and gratitude for more pro-social behavior. So for instance, saying, thank you so much for your patience if she didn't actually shout when you're a minute late. So giving that positive feedback for behaviors that we want to encourage. Also agreed that, okay, we can't always get medications there right on time. It's just not how long-term care works, but staff agreed that they could give them within a 20-minute window. So that has to be something that's feasible and agreed upon with staff and with the patient or the resident. She was also seen by the activation coordinator, who found out that she likes knitting. So they arranged to have knitting materials brought in. Her daughters agreed to pay for a television in her room. So just some more positive activities that can help to distract her and provide that emotional regulation. She was also linked with a volunteer for friendly visits every week. They found that she likes talking about the maple leaves, so she would do that with the visitor. So again, just encouraging some more positive behaviors. And then the DOC and the family physician agreed to meet with her alternating every week to review concerns and problem solve. If she complained to other staff, she was advised just in a neutral manner to write the issue down and save it for her meeting. So that was to help alleviate some of the distress and burnout that, PSW staff, for instance, were experiencing. So everyone was advised of the care plan. It was placed in her chart, flagged for agency staff to review. She was given a copy. So everybody was on the same page. And then staff also scheduled monthly meetings to review her care plan and problem solve any new issues. Okay, so in terms of outcome, so there was an overall reduction in calling out, angry outbursts, and staff stress levels, but regular staff would occasionally have to remind agency staff to review the care plan to promote that consistency, and would have to kind of regroup to make sure that we were still using a consistent care plan. But staff also noticed that behaviors would increase with any stressor. So for instance, a fall with increased back pain, a favorite staff member leaving, and this would require staff to kind of meet, problem solve, and update the care plan periodically. And that's common. I mean, it's, this has been a lifelong behavior. It can get better, but it's not going to totally go away, and it will have its ups and downs over time. Okay, so that's everything from me. So I wanted, again, to just leave it open for questions and discussion. So I guess would the best way to use the chat, do you think?
Yeah, the chat or the Q&A
okay.
is fine.
I think I can monitor the chat actually.
Okay.
Let me do that. And I'll also ask people, like, if you have had experiences that have worked, like if you found things that are helpful in managing patients with this personality structure in long-term care, it would be helpful to hear that as well. So, benefits, challenges, questions, anything like that. You can also probably use, speak, unmute and ask a question as well. I'm fine with that. How to re-engage staff once they've given up on them. Yeah, so I have some ideas. I'll see if Holly has some ideas too. So, oh, great. Holly shared the practical. Yeah, so that's a resource. A resource, yeah, it's a chapter from a textbook on mental health and long-term care that has some good resources as well. So anyway, so the first question was how to re-engage staff. So, I mean, I guess by the time I come in, it's usually there's been a lot of distress. And so what I've kind of done to try to help with that is actually helping to develop a care plan. And in the process of developing a care plan and staff meetings, Holly maybe can let me know, but I found that can be a way to start to re-engage staff. So to have a specific interdisciplinary meeting about it, and also provide some education as to what is probably going on. So if people, staff don't necessarily know, why is somebody acting like this? I mean, it really doesn't make sense. So it can be helpful to have a bit of a discussion about why somebody might act in this way, and what are the strategies that can actually help. So feeling like we're moving towards a goal is I think can be helpful in re-engaging staff. I don't know if Holly, if you
I would reinforce the education, providing them the reasons why they feel like they feel after. I think once staff are able to understand why they're feeling the way they're feeling, then that I have found that helpful. And again, management are pretty key here and need to be involved with these residents and supporting the staff and offering some staff movement if the staff are that burnt out, doing some circling of staff.
Makes sense.
And I think we've even had where the resident themselves have moved floors to give the floor a break as well. So, I mean, it is individualized, but it's really listening to the staff and understanding their views.
Makes sense. Yeah, no, and it is difficult. I mean, I know it's easy for me to say, okay, this is the care plan, this can work. It takes a lot of time and effort to enact it. So for sure, staff might just need a break. That's common in managing people with personality disorders. What is the process for getting someone in long-term care diagnosed with a personality disorder? My involvement. So generally speaking, if people have behavioral symptoms or challenges and a diagnosis is thought to be helpful in managing it, then I get, the first step, at least where in SGS, is a referral to the SGS long-term care team. And then they bring it to rounds, and then I would get involved, or Dr. Daniel. So it would be involving the SGS long-term care team. And does that, I think that's probably.
Yeah, I would think a referral to our team if they're really looking for that. Yeah.
Yeah, no, I get involved. I mean, sometimes I'll say, well, I mean, there's not a lot of like medication strategies that can be done, but at least, you know, we can kind of help with the diagnosis and the care plan. Okay, and Brian says, do you have any strategies to stop these residents from continuing to call emergency services? Yes, that's a challenge. We have that in the hospital too. So I guess a couple of things, like the first thought would be, is there a way of kind of analyzing why they do it, when they do it? Like, what's the pattern of calling emergency services? Is it after they've had a stressor happen? Is it like in the middle of the night? You know, I'm assuming here that this person does have a likely personality disorder. They don't have dementia and they're like worried, you know, they have psychosis or something. It's behavioral, right? So in that situation, I think the first step would just be to try to understand what the triggers are, because maybe they could be modified. That could involve involving our service to help with that. If there's nothing, like if there's really, you know, no modifiable trigger, then I guess the second thought I would have would be to see if we could develop some like behavioral care planning around that. So it could involve either saying to the person, okay, when you have a complaint that you're gonna, you know, call 911 about, can you first call this person? Like the first step is to call, you know, ask for a meeting, for instance, with the director of care, or like have that designated person as the outlet rather than having them reach for calling 911 right away. So that might be one strategy. Another strategy I could think of would be to actually use like maybe a reward system. So for every week or whatever that they don't call 911, is there something positive that they could get? So kind of like a bribe, you know, so that token system to try to encourage them not to call 911, maybe using reward rather than consequences, or using both. So I think it really depends on what they're getting out of it. Like the question is, what are they getting out of it? So usually it's going to be a way of seeking attention that's not adaptive. So is there another way that we can do that? So maybe a pro-attention plan would work as well. So yeah, so I mean, feel free to, you know, involve our team if there is a question around the behavioral, like if behavioral management can be helpful, because I know that's challenging. What tools do you use? So Amanda says, what tools do you use when diagnosing someone to have a personality disorder? So I just use the DSM criteria, and I have to say it is hard in long-term care to make a definite diagnosis of a personality disorder without collateral. So if collateral is available from family, just so I know that this has been a lifelong pattern, it's not a new pattern, then that is necessary. If I don't have that collateral, I just sort of rule other things out. Like I, you know, rule out significant dementia, psychosis, depression, anxiety, etc. And if those traits are still there, I'll say, well, it's probably a personality disorder. But without a lifelong collateral, I usually won't make it a definite diagnosis. But ultimately, that doesn't really change management. Like we would, you know, if we ruled out other things, we would still manage it in the same way, whether they have definite borderline personality disorder or borderline traits. I mean, you're still going to use the same management. So yeah, so I mean, it's a clinical diagnosis. Okay. Nancy says, family that don't speak with one another, the parent, oh yes, the parent is extremely difficult and family don't want to visit. Yeah, that's, I think, a common issue because this has been their lifelong pattern. So family really has probably been burnt out as well and aren't able to visit. So I think in that case, it's probably helpful to have a designated family member, like not having them both calling, and, you know, like sometimes the parent can be splitting among the children. So it's good just to have like one, like the POA as one designated person who's the spokesperson for the family. If they don't want to visit, I mean, you know, unfortunately we can't force it, right? So it's maybe thinking about, well, what are some other pro-social things that can be done? Like, would they benefit from friendly visitor if they're able to, or chaplain or other things like that? Okay. Shannon says, we had one resident that we started a game with asking a trivia question on the fly. Oh yeah, they got a positive interaction and staff didn't have to spend a ton of time. It helped to build some of the relationship. We have advocated for a few extra minutes for staff off the floor after care with them, and bins of candy are a hit. Yeah. So I think that's a great idea. So identifying an interest that a person has and using it to build a positive interaction. And I would think that that actually helps staff to feel more positive too, because they've had a positive interaction. It's not always that really negative interaction, right? So trivia is a great idea. I hadn't heard that one before.
I think, Shannon, is referring to our fizzy candy theory.
Yeah,
I think that's what we're always trying to get staff to suck on a fizzy candy after
just
managing with
having
residents.
some time to decompress. And I think also,
Yes.
From a management perspective and from, our team's perspective too, just really giving the staff credit for, for their hard work in managing patients with this personality structure, because it really is extremely, difficult, and it feels really personal even when it isn't. So being able to support staff and give them, giving credit and also giving some of that extra time, I think is great. Okay. Kate says, sorry, we have a lot of good questions, so I'm just trying to make sure I get to as many as I can. Okay, Kate says, any tips to manage the countertransference that can occur between the patient and some staff? So that sounds like managing countertransference not in oneself, but when you notice it in other people. Certainly the first step is recognizing it and naming it as such. Like, you don't need to call it countertransference necessarily, but sort of saying, well, providing that education about, especially if it's been a diagnosis that the person has, to say, well, this is what's going on with them. It's not uncommon for people with this, personality trait or personality structure or disorder to really elicit strong feelings in other people. And so providing that education and saying it's not personal to you, it's often a reflection on how they feel about themselves. And then maybe sort of collaborating and problem solving on, well, what can we do to help with the stress that you're feeling and managing this person, just so that, often we have trouble managing our countertransference when we're stressed and burnt out and don't know what's going on. So that education can help. Collaboratively problem solving with the staff member experiencing the strong countertransference can help. Like, it's really necessary to work as a team to manage people with this, residents with this personality structure. So I think, again, first recognizing it, naming it, and then talking about, well, what are some strategies that can help? Hopefully that would be helpful. It's not always easy though, for sure. Okay, candy solves everything. Yeah, agreed. Okay, Terry says, what about a younger person, no cognitive impairment, own decision maker? Yeah, no definitive diagnosis, just reference to cluster C traits. So cluster C is the dependent, avoidant, obsessive compulsive traits. So I guess, I don't know if Terry, you can type it in the chat, but is the issue that they're like not managing their care adequately? Or you can say it too, whatever you're comfortable with. Because I think if they're not, managing their care properly, or you have concerns about their, refusing care. Okay, I see. Yeah, nothing is helpful, drug seeking. Yeah, so I wonder if that's not necessary. I don't know. I haven't done an assessment, but that's not necessarily classic of cluster C traits. And I know like younger people in long-term care are a challenge, in and of themselves, for them, obviously, as well as for everybody. So I think that the management would be the same. Like most people with borderline personality disorder that I'm kind of referring to here, the challenges are not when they develop dementia. That's not necessarily when it's the biggest challenge. It's when they're still cognitively intact. So I think it would be the same kind of management. Okay, Rachel says, okay, wait, hold on. Terry says, we're trying to get a consult. Sure, yeah. Oh, yeah, okay, I don't know if you're in my region. I do see younger people in long-term care because there's not a lot of other options. Maybe, Terry, maybe you could connect with us afterwards. Does that make sense, Holly?
Yeah, or even whoever your RN team lead is, to connect with your team lead for some further discussion.
Because yeah, I agree. That does sound like it would be helpful to have a consult. And, I can't always like long-term follow. I don't long-term follow young people in long-term care, but because there are no other options, I do see anyone in long-term care. Okay, hold on. Yeah. Rachel says, in her experience, staff struggle with giving in, yes, and some are on board with maintaining boundaries. For example, the resident is demanding certain staff to do their care who are not working on their hallway that day. Some say they would comply to avoid a negative behavior or complaints. This increases burnout and inconsistency. So they would coach maintaining boundaries. What are your thoughts in explaining to staff residents' rights to choose versus boundaries in regards to caring for someone with a personality disorder? I mean, I'll share my thoughts. Holly might also have some thoughts too, but I think in the case where, like, let's say, you know, there just isn't staff available to provide care, like the person that they want to provide care. I mean, presuming they're cognitively intact, they have the right to refuse care, right? So, and staff, you know, need to stick to the care plan. So if the care plan, staff, I think, need to be educated that sticking to the care plan is going to make it easier for all of us in the long run. So even if it makes it a lot more difficult for that shift, which it will, unfortunately, it has sort of the longer term view of making things a lot easier, or maybe not a lot, but easier on the whole. And so understanding why we're sticking to the care plan so consistently can sometimes be helpful, I think. You know, to me, I think if somebody's refusing care from the person who's on that hallway that day, then that's their choice to make, right? And they don't have to accept care from them. They kind of will have the consequences of that. You know, and then they eventually, I'm sure, will accept care at some point, and it has to be communicated to them in a neutral manner too. So if there's a care plan in place, you know, that care plan might include, you know, the staff on the hallway that day will be the one to provide care. And then when they're asking for a different staff, just reminding them and saying, well, this is part of the care plan. So, you know, if you're not going to accept care from me today, then okay, there's just not another option right now. You can discuss it at your next meeting with, you know, with whoever. So that would be the way I would approach something like that. I know it would take some time though. It's not something that's going to be solved in one interaction. I don't know if Holly, is there anything else that comes to mind?
I would agree. I think in our situation, in the climate of long-term care right now, it's pretty hard to be choosy when there might not be enough staff to be choosy about. So I think that the clear care plan stating that whoever's on your section is who will be providing care, and you choose to whether to have it or not, and then have that in the care plan. Or like we have those positive care agreements we've used before with people as well. So we can always share, whoever your RN team lead is, we can always share that with the home.
Yeah. I mean, I think if there's somebody who that is becoming a challenge and staff are kind of giving in, which is understandable, right? To just make their lives as easy, like not as easy as possible, but a little bit easier for that shift, then that might be a time when a care plan is needed, right? Because then there's that document that provides the ability for staff to use a very consistent approach. So the care plan's been agreed upon, and staff can just say, oh, it's in your care plan. So you can either have care for me now, or you have to wait till tomorrow. Or, you know, the other thing you can do is say, well, you have to have care from me today. We can either do it now or we can do it in an hour. Like there's ways of trying to give them a little bit more choice. Like often people with certain personality structures do benefit from having that agency and choice. So sort of, you know, giving a little bit of choice, but not outside the bounds of the care plan that's been developed.
Yeah.
Kathy says positive care agreements. I think that's like a care plan essentially.
It's
right?
like a contract. We just thought it sounded better to say positive care agreement.
It does, yeah. It sounds good.
And Terry Adlam, I was just wondering what home you're from so we can try to hook you up with some supports. Because she had asked if you do OTN, which obviously we do OTN. So
yeah,
if you
it just depends.
Private message me.
Oh, Waterloo.
Waterloo.
Oh.
You're in a region.
It's great to have people from outside our region. And we can follow up as to, I would imagine in Waterloo, Wellington, it would be the you might want to ask the specialized geriatric services, call their central intake, because they may say if someone's in long-term care that even under the age of 65, they may agree to see that individual.
Yeah, I mean, we like, I can't speak for them, but we have flexibility just because there are so little resources otherwise. Mm-hmm. So hopefully, I hope so.
Sorry, the other piece, Terry, if you're looking specifically for psychiatry or geriatric psychiatrist in OTN, you can go through the OTN directory, because there would be other psychiatrists that probably, if the specialized geriatric services wouldn't see within long-term care in your region.
Yeah, I'm unfortunately not too familiar with that region. I'm in Toronto, but work in North Simcoe, Muskoka. Geriatric Psych says we need, oh gosh, yeah, I know. It's so difficult.
Yeah.
Yeah, it is. I mean, I bet you could probably find a psychiatrist through OTN who would do that. I used to go into long-term care, even though I wasn't aligned with SGS. So there hopefully is somebody out there who will do that, just because it sounds like even a diagnostic assessment would be helpful.
Mm-hmm.
Okay, we'll see if anyone has any kind of final questions. It's a great discussion.
Okay.
All right, and I did, oh, sorry, Tamara, I was just gonna say we did provide in the chat that resource, which it actually, it's a chapter that essentially summarizes, or it goes actually into more detail about some of the things that I covered today. So I think it can be useful.
Yes, so thank you, Katie, for speaking with us. I think in hindsight, I should have done this as a meeting, not a webinar, to be able to engage more interaction. But this has been, I think, for the discussion with it, even within the chat box, I think this has been great discussion. I think for me, you reminded me of, when engaging with someone with a personality traits cluster, that it's not personal to me. It's the feelings that I have are probably that reflection of how that person is feeling, which really highlights to me awareness, and then helps to understand where that's coming from and that it's not personal. Mm-hmm. So thank you very much.
Thank you. Thanks, everyone. Thanks for participating.
Thank you.
All right.
As I said, this will be on our website, North Simcoe Muskoka website, in the education, special events, and workshops section, probably in about a week.